Minutes more.
Oh, like you said, started, so I started. Go ahead, Andrea, start.
No, I say let's wait a couple of minutes more.
It's already recording.
Okay, I see many other people are joining. Okay, maybe it's time to start now. Millie, can you please start the recording? Good morning, everyone, and welcome to Montier today. Today we have an internal speaker, Pier Pasquale Lione, from our structural team, and he will cover a very interesting topic, which is what is hot in the field of aortic devices. Thanks, Pierre, for giving us this talk.
Oh, thank you. Thank you guys for giving me the opportunity. I think it's 2025 and there's a few hot topics when we deal with transcatheter aortic valve replacement. And I think it's a pretty contemporary issue, and I think it's a reasonable time to speak about this. So without further wait, let's see if we can go forward. So number one, I think the field itself is hot itself. So this is just a proportion of TAVR among AVR procedures across Europe, especially France and United States. And you can really appreciate that, especially in the United States, when you start going in 2020 in patients that are 65 years of age or more, it really gets down to mostly TAVR procedure in this kind of patient. So it's something very contemporary, and we really need to try to get the best results possible with the best devices possible, especially in these young patients. And that's one reason why I think it's really important to know your devices. So often also in PCI, people refer to it as being an artisan. So it's a craft. You need to know what devices you're using, why you're using them. And I think the same applies to TAVR. There's different characteristics in patients undergoing TAVR that we really need to recognize in order to actually predict possible complications. And since we predict complication, we want to know what's the device best for us in that setting that we can use to avoid that complication. And if we look at the different devices available in 2022, this is from a review from our group. 3 years ago, these were pretty much the valves that we were looking at when we were dealing with the different platforms available for TAVR. And in 2025, you can appreciate already that there's many more. There's new valves and there's new iterations of old valves. And in general, when we go and think about TAVR, and in general, any kind of aortic valve replacement, be a patient of 50 years old or be a patient of 80 years old, what we want to do is to have an optimal valve performance, have a very simple and predictable deployment with a procedure that has a low complication rate, and with a result that's durable and has minimal interference with the surrounding structures. And in general, if it was me, my ideal heart valve would be a heart valve that you can implant in one procedure alone, and it really gives you a normal lifestyle. So it really gets down to, does this valve need an anticoagulation? Does this not need anticoagulation? And when we look at the landscape, there's very many different devices. And I think we can really group them in different groups according to their history and their future. So there's current industry standards. So there's a couple of platforms that have been going on in the past 20 years. They really were born with TAVR and have been having further iterations on and on. years after years. And then there's valves that are increasing clinical use and are really next in pipeline. So they're either about to get commercially available or are kind of recently commercially available, for example, in the US. And they're starting to be used a little bit more. And then if we step back a little bit more, there's other valves that are increasing in momentum. They're maybe still in their early feasibility of people studies, but are really promising. There's valves that are kind of rebooting. So they had some previous iterations that had some issues with any kind of valve performance from the delivery system of the valve itself and are trying to get better. And then, of course, at the bottom, there's valves that either early or later at the demise and are now out of the market. So rising platforms, as before, we can really capture them in self-expanding mechanisms of expansion on the left side and balloon expandable valves. You know, appreciate here, there's about 12 valves. I think we're going to touch upon a few of these during the presentation. And rather than, you know, going on valve by valve, I think it's reasonable, more interesting for us to really go and look a little bit at the process of the development of these valves. And while we do that, we can touch upon a little bit of these technologies. So in general, the randomized trials have established TAVR as a therapeutic option across the spectrum of risk. These are all the studies that were conducted with the SAPIEN valve. And of course, we started with patients that couldn't undergo surgery or were at high risk of surgery. And then we went down to patient at intermediate risk and patient at low risk of surgery, risk of mortality after surgery. And this valve, the SAPIEN iteration, the SAPIEN family of valves, has really been going on for the past 2 decades. And it's evolved during these 2 decades. And you can see how the different French sizes of the delivery system have decreased, how the skirt has been more represented on and on. The outer skirt on the valve is very important for really mitigating the risk of perivalvular leak. And on the right-hand side, you can really see a kind of a card of this latest iteration. It's the SAPIEN 3 Ultra Resilia, which, you know, as the previous valve, has a short stem frame in triannular leaflets, and it really has a very thick skirt at the bottom half of the valve that really mitigates the risk of perivalvular leak. It's FDA and CE mark approved, and it's been used for post several years. On the other hand, if we look at the self-expanding platforms, one of the most used and the one that was born really also about 20 years ago and it's evolved since then is the CoreValve and Evolut family of valves. And on the right-hand side, you can see the Evolut FX Plus, which is the latest iteration we've been using at Monty as well. And it's a nitinol valve that's self-expanding with porcine leaflets. And its annulus range treatable goes from 18 to 30 millimeters, which is pretty wide. And the delivery system is pretty actually thin. So it's kind of useful, especially when you have very small anatomies. And in general, self-expanding valves are really helpful when anywhere you have small anatomies or calcified anatomies. That can be very, very useful. When we go forward now into the 3rd decade, we need to look at what's going on in terms of developments, what we can do to make procedures better, make patients feel better right away, have them recovery faster. So number one, of course, is the acute procedure optimization. We can optimize delivery system, the sheet sizes. We can optimize both implantation techniques and valves to reduce the risk of conduction issues. PVL solutions, meaning the risk of PVL with some valves remains a little bit higher than others. So we really need to understand what's the best mechanism to mitigate this risk. And of course, we have different patients, different sizes, annular different. So the aim to achieve a personalized sizing specific to the patient is really helpful. And in general, at 30 days, contemporary benchmarks that we need to look forward to are the following. So a risk of all-cause mortality less than 1%, a risk of major stroke less than 1%, risk of major vascular complications less than 3%, and single-digit new permanent pacemaker and no moderate or severe PVL. I think in 2025, these are pretty reasonable. And when we look at PVL mitigation, there's a few ways that we can really try and do that. So in general, number one reason is that we have very clear evidence that having moderate perivalvular leak or perivalvular regurgitation is really associated with bad outcomes. But also, we have some rising evidence, and actually also from the very first trials with the sapien valve, it was already seen that starting 1 or 2 years after procedure, already having a mild paravalvular leak is not good for you. So Fabrius curves on the left, we see the sapien valve and the Navitor self-expanding valve on the left. And on the right-hand side, the Evolut and Accurate Neo2 platforms. They have instead pericardial wraps. So two different ways to try and target the same issue. And this is just a deployment, typical deployment of Navitor Vision, which is the latest iteration of Navitor. You can appreciate nitinol, just like the previous self-expanding valve we've seen, with a bovine pericardium. Very wide range of sizes in order to treat patients with very small and very large annuli. And the previous iteration were the Portico and Navitor. The Navitor Vision on top has this, at the bottom of the valve, there's these 3 little dots that really help also in commissure alignment. In terms of permanent pacemaker implantation, we know this as well is associated with worse outcomes. I report here a study that was led by a multi-center study, was led by the guys in Turin, and we've shown actually that, you know, the higher the pacing also, of course, the worse the outcomes. So the risk of permanent pacemaker implantation needs to be mitigated. And on the left side, you can appreciate one of the things that we can do, that is focus on the implantation technique. On the right-hand side, instead, there's some valves that were really made for having kind of less hindrance and less trauma to the conduction system. And the Accurate Neo, Neo2, and Prime were actually one of these. And this over here, you can see it's just an example of the Accurate Prime release, which is the later iteration, which has a little bit higher radial strength to mitigate the risk of underexpansion. Number 3, I think these aspects are all intertwined. Control of depth, horizontal aorta deployment, and commissure alignment. All of them are really interconnected with the delivery system as well. And the Sapien X4 on the left, which is the latest iteration, not commercially available yet for the Sapien valve, and the Evolut FX and FX Plus really tried to help in having a deployment that's easier, more controllable with different mechanisms. So on the left side, you can see the active flexion knob, which is actually present already with the Sapiens before this iteration. But on top of that, the Sapien X4 has the possibility to have an independent commissure alignment so that we can make sure that the valve that we deploy, just like we do in surgery, it really is commissure alignment to the native commissures of the valve. On the right-hand side, you have FX and F Plus. In particular, they have the 3 dots at the bottom, which really help just like the Navitor for commissure alignment. And there's just a single spine. Used to be 2 spines before. They were really kind of keeping the delivery system a little bit straighter for support to trackability. And at this point, Medtronic managed to find kind of a way in between to have the good support and trackability of the delivery system, but as well try to have some flexibility for a little bit more tortuous anatomies. And this slide, I think, reflects what when people think a little bit out of the box. And I think it's always good to think out of the box, especially in this kind of situations. So we know that the larger the sheet, the more the complications. And as we saw before, we ought to have risk of major vascular complication less than 3%, but that's still a little bit. So other companies, just like these two over here, have tried ways to reduce the sheet size and reduce the risk of major vascular complications. On the left side, very interesting concept is a modular design, meaning the valve is composed of 2 parts and they're released one after the other, so that we really do not need the whole French at the same time, because we can deliver little pieces of the valve one after the other. And it's currently 12 French compatible, but they've been working, and first cases have been done with 9 French deliveries. On the right-hand side, it's the Sequel. It's a very interesting technology, and it's a new stent technology that really allows to deliver this valve through an 8 French system. 8 French system is pretty much the same system that you would use sometimes for complex PCI. So the goal of having less than 10 French systems is still something attainable, and it's something that we should look for, especially when we start treating very, very low-risk patients. This is just further details on the Geminos. I think the right-hand slide is very interesting. You can see how we go from the Sapien delivery system on top right, and we go down to the Geminos delivery system. You can really see the difference and how you can really predict how the risk of having complications getting smaller is really getting smaller as well. And one other aspect of this valve is very interesting, is that it has this external hydrogel-based layer that kind of inflates once it's in the body. So it really also allows to have a very, very thin delivery system, but once it's in the body, it gets thicker and it prevents PVL. So I think this is a very interesting technology. And also the Seagull valve that we've seen before, it's very interesting. This rhenium superalloy allows to have very few cells, just 18 cells, 9 cells per row with 2 rows only, with a crimping profile that's very low, clearly easier coronary access, but especially there's no foreshortening when we deploy the valve. When we deploy other balloon expanded valves, but also self-expanding valves, we expect a little bit of foreshortening because the valve is squeezed into the delivery system. Whenever we increase its radius, it's gonna come up. And in this kind of technology, we really managed to have 20 millimeters of the valve crimped and 20 millimeters when it's delivered. So the deployment is very predictable. This is just the M sheet, which it's an 8 French sheet, and you can appreciate the handle with the commissure alignment knob, the fine adjustment, and the flex knob. So also this one, it was very recently presented at TCT 2024, and I think it's a very promising technology. And as we were saying, I think also personal sizing is important. And here is a video on the bottom of one of our procedure with the Sapien X4, which we've seen earlier. And it really has 3 valve sizes, but 16 unique deployment diameters, which allow us to deploy the valve at certain ranges that we really think are appropriate for the anatomy of that patient. So we have a 26 valve, and we can deploy at 24.5 all the way up to 26.5. And as we said, as an independent commissure alignment knob that really helps also for future valve-in-valve. Another way, whenever we're dealing with personalized sizing, of course, either we have 3 valves and we can deploy them a little larger, a little smaller, like we said with Sapien, or we just have many valves. And this is the MyValve OctaPro. It's the latest iteration of the MyValve family. It's very similar conceptual to a balloon expander valves, just like the Sapien. And here we have valves that go from 20 to 32 millimeters with increments of 1.5 millimeter. So with this, we can really tackle very large, very small anatomies and anything in between. So we've seen acute procedure optimization issues and what we can do about that. But then, there's many questions that remain when we look at long-term durability and lifetime management. And I think hemodynamics remain very important, especially when we look at young patients. Hypertonated leaflet thickening or HALT is always an issue that's been going on for a few years now, and we still haven't understood very well how to deal with that. Coronary access as well, and of course, therapy sequencing. So the risk of TAVR failure and future TAV in TAV. So long-term durability. We have the first data from the first studies that were conducted very, very early in the days, and it's promising data. Unfortunately, of course, there's many people that during the follow-up have been, experiencing death because the patients that were treated were high risk and were kind of elderly. So what I think is really important is to wait for the long-term follow-up of studies that were conducted in younger patients at low risk that really can help us. These are some data from Notion trial and UK TAVI registry, definitely some promising results, but I think we need more data to be able to tell our patients what our expectations are whenever we tell them that we're going to do a TAVR procedure. In terms of durability, of course, one thing that we can do is work on the leaflets. The leaflets are the ones that are exposed to the hemodynamic insult of blood going past it. So this is one of the Resilia tissues that have been used with the Sapien technology. This in particular is Sapien X4, but we've been using already commercially the Sapien 3 Ultra Resilia. And it's a way really to prevent the exposure of the aldehydes in the leaflets. We can really hopefully decrease the risk of degeneration. We have to imagine that whenever we use leaflets from the pericardium wrap of either bovines or ovens, I think porcine, the risk of having DNA remaining, of having phospholipids, or having any kind of substance that can really trigger an inflammatory response and degeneration of the leaflets is still a risk. So anything that can really get rid of any of that might be helpful. This is the Resilia tissue that we said, and this is the DuerVR. This is another way to tackle this problem, and these are biomimetic leaflets which have been treated with anti-calcification, antifibrotic adapt tissue, said they really try to have no risk of foreign body response to them. And also, these leaflets are very particular because they are not actually 3 leaflets. This is just a single piece of tissue that's wrapped around, and it opens very well. And one of the strongest points that this company is really sustaining is that the hemodynamics with this valve are very good. And you can appreciate on the bottom slide that at discharge, 30 days, and then a follow-up, the effective orifice area remains above 2. And you have to imagine that this valve right now has been implanted with a 23 millimeter size, which is pretty small. So having a 2 of effective orifice area with a 23 millimeter valve, I think it's very promising. And you can really see that the gradients do remain low. So I think this is a technology that we need to keep under sight, and hopefully can really guarantee hemodynamic sustainably good, also long-term follow-up. This is one of our cases performed a few months back. 23 Dura VR. This was inflated with extra 0.5 cc's. And on the right-hand side, after deployment, you can really see that in the diastole, the independent commissure alignment with this valve really allowed to have the valve aligned with the commissures and have easy coronary access for the patient afterwards. In terms of other biomimetic valves, this is a TRIA, which is from Foldex. It was born as a valve in the surgical world. Then they started producing and working on a balloon expandable platform that you can appreciate on the left-hand side. Then they stopped that and they switched over on a self-expanding valve. And it's robotically engineered. It has also an electrospun polymer skirt that really enhances both anchoring and ingrowth of tissue. And it's still, back in very early studies, but I think it's also reasonable to take a look at this valve in the future. In terms of, we've been dealing with forward flow hemodynamics and elevated gradients. There's always evidence, and there's been always evidence that the lower the gradient, the larger the effective orifice area, the better the outcomes. But with TAVR, it's been a little bit more different. So the risk of having prosthesis-patient mismatch after TAVR, as measured by echocardiography, it's not always been seen as something associated with worse outcomes at follow-up. Might it be for short follow-up? Might it be for other confounding bias of observation retrospective studies? But these over here are some publication on the left-hand side. It's New England Journal of Medicine that we looked at patients treated in small annuli with balloon expanded or self-expanding valve. No differences in clinical outcomes, only at 12 months follow-up, which is very short. But you can really see that the rate of bioprosthetic valve dysfunction, balloon expanded valve, is 4 times higher. So will this translate in clinical differences at long-term follow-up? We'll see. And on the right-hand side, this is just a publication already from 4 years ago from our group. And we did show that in patients with small annuli, the risk of having a severe patient mismatch after TAVR was associated with a worse mortality rates. So in this kind of situation, we always try to implant self-expanding valves in very small annuli. You can appreciate over here on the left side, very small annulus with a 20 millimeter average diameter. Other companies like Allegra, this is a valve that's been used in Europe. It's a valve with very optimal hemodynamics, and it really allows to have optimal flow, especially in valve procedures. As I said, the implication and management of HALT. So anytime we see patients that develop this hypoattenuations at CT scan, but are not clinically evident, we still don't know how to deal with them. Sometimes they regress by themselves. Sometimes we need to give them anticoagulation. Sometimes anticoagulation with DOAC is not enough. We give them Coumadin. Sometimes it's enough. So this is something that was presented 6 years ago, and I don't think we're really far away from that still. So I think there's still a little bit of work to go on in these terms. And of course, and I'm just going to touch upon this because this is a huge chapter, the lifetime management of patient undergoing TAVR is really important. So when we treat a patient at 65 years old, we always need to think, okay, we're going to implant this valve. But in 10, 15 years, when this valve is going to fail, what are we going to do? So I think it's really important to look at the patient and look at its lifetime. And anytime now that we do a TAVR, not only to the TAVR that we're doing, but also to the future. And here, another issue, and it's still related to the lifetime management of the patient. If we have patients with coronary artery disease and aortic stenosis, it's always a management of most procedures because the coronary arteries and the aortic valve are very close to each other. So some valves, like balloon expandable short frame valves, don't have this kind of issues, meaning that they're very short. So oftentimes there's no risk of having any impingement or hindrance on the coronary artery ostia. But then when we deal with self-expanding valves, we need ways to actually facilitate this kind of cannulation of the coronary arteries in case we have acute coronary syndrome, in case patient develop chronic coronary syndrome. And on the right-hand side, you can see the latest iteration of the Evolut FX Plus that we've seen already. That really has a 4-cell wide hole that really is supposed to be once commissure alignment is achieved with the valve right in front of the coronary ostium. So this should, and it's, hopefully helping with coronary cannulations. And finally, I think there's some specific therapeutic targets that are really a little bit out of the ordinary. And I think that we really just can spend a few minutes talking about them. Bicuspid aortic valves, one. So bicuspids are a very large family of patients. Not bicuspids are all the same. So over here, you can see on the left-hand side that the newer generation devices in general, the generation devices were actually developed for AES, are giving better results with respect to old generation. And on the right-hand side, you can see that there's a little bit of a trade-off when we deal with balloon expandable valve or self-expanding valves. So the risk of permanent pacemaker implantation is higher with the self-expanding valves, but they also give better hemodynamics. So it's a trade-off, and you really need to tackle these kind of patients according to what you think is better for the patient. And this is just from China. These are 3 valves that have been developed. China has a very actually larger proportion of patients that have bicuspid aortic valve stenosis. So much of the market has been working on valves that can have really radial strength that's supporting enough to be able to tackle these very calcified valves and make sure that the valve is very well expanded. So there's Venus A Pro. It's the latest generation of the Venus family, the VitaFlow Liberty, and the Taurus one. Very similar, somewhat different, but in general, the high radial strength is one of the things that really characterizes all of them. This is just the latest iteration from the Venus Power X and Venus Vita platforms. Just touch upon these because the Venus Power X is a self-expanding valve with right tissue technology, and it's 100% retrievable after 100% deployment. I think this is pretty interesting. And then on the right-hand side, the Venus Vita, which a balloon expanding counterpart, still with right tissue technology. When we go finally on the last group of patients, all the TAVR sphere has been dealing with patients historically with aortic stenosis. But then we realized that a lot of patients with aortic regurgitation are actually not being treated. They're not being treated because oftentimes they end up being too high surgical risk to undergo surgery. So that's why a few companies then have concentrated their efforts to develop valves that were really destined to be treating patients with AR. One of them is the Trilogy, which is the second iteration of the Jena valve. And it really has these locators that can really be helpful, number one, to hold on to the leaf. Let's go, because we need to remember that the valves in AR don't have calcium. So most of the valves in aortic stenosis, they really need the calcium to anchor on the valve. So these valves are not calcified. So the locators, number one, help with anchoring. Number two, they help with commissure alignment. So you pretty much get 2 for 1. And I think data is very promising. Latest data has been published in the Lancet last year. And we'll see this technology where it'll end up. But I think I'm very positively affected by the results of this valve. Another valve is the J valve, which itself also was destined with patients with AR, but they actually both AR and AS. So both J valve and Jena valve can treat both patients with AS and AR. And the mechanism is always the same. In this case, the J valve doesn't have the locators, but it has an idonal anchor ring. Very similar concept. It sits on top of the leaflets, and then the valve is expanded upon this ring. So the leaflets are kind of squeezed between the ring and the stent of the valve, okay? And same thing, the rings help with anchoring and commissure alignment. And I'm just going to touch upon a couple of more valves. The optimum valve, it's a short stent frame self-expanding valve. All the self-expanding valves that we've seen so far, they have a very tall frame. And this really helps also for valve anchoring and stability. This valve is the lowest self-expanding valve height and apparently has no suture holes in very important flexion zones. So it's very early in the stages, and let's see how we end up with this valve. And finally, Abbott has been working recently with a new valve, which is a balloon expandable valve. It's a software and AI-guided deployment, and as the possibility of having a procedure that's single operator, because with a simple button, you can release and deploy very predictably the valve itself. So this was presented by actually Dr. Lateeb in London in November 2024. And I think we're really eager to see what's going to happen with this kind of technology. Hopefully there will be further studies early in 2026 already. So just a summary slide. Today, there is no single perfect TAVR system. It's always a trade-off. If we think of paravalvular leak, we want a good skirt. Having a good skirt, we have to pay the price of having a larger sheet. So right now, we need to check what we need in one specific patient and go for it. And of course, when we deal with operators, there's a very strong subjective opinion, which also varies with the type of procedure that that operator does. So not all operators might be comfortable with any kind of procedure. And I think, hopefully in the future, we can have TAVR systems that are really excelling in all their aspects and can be expected to treat all kind of patients. And hopefully we can have valves that are really, really good for young people and patients with bicuspid aortic stenosis. Novel device designs are about to enter the market. We've seen some of you. And the interplay between the devices is as important, especially until we get a valve that's a TAVR valve that can last 30 years. So if you want to know more about the recent developments, we're presenting at CRT in a couple of weeks, late breaking trial on balloon expandable versus self-expanding valves. So feel free to join us. And thank you so much. Feel free to ask any questions.
Thanks, Pierre. This was a very great talk. You covered everything from the history to the new iteration of the devices and what's in the future. Just as a reminder for everyone, whoever wants to ask anything, please use the chat. Maybe I'll ask with a question for you, and then we will see if the others have any other questions. So just to summarize, we want these valves to have fewer complications. We want valves to last longer. And also it's very important to keep the option open to do another valve in the future, and potentially even more than one, especially as we treat younger patients. We saw in your slides that many valves are being developed, many different designs, short valves, tall valves, self-expanding, balloon expandable in different countries around the world. So what do you think is going to be the future, especially since you also show that we are treating younger and younger patients, especially if we move also to the AR population? Do you think that, especially for companies producing both valves, self and balloon expandable, do you think there will be a prevalence of one or the other? How do you think the market will change?
That's a great point. I think ideally, if you're a company and you have both a self-expanding and balloon expandable valve technology, then I think unless you have designs that are not really contemporary, you should be good. So you can treat patients that have very, very severe calcified anatomies they're not amenable to balloon expandable valves. And then for any other issue, you can have very predictable deployment with balloon expanding valves. So I think in general, if I were to pick and if I were to imagine a valve that was going to last, hopefully 15, 20 years, I would love a valve that I can deploy very predictably. I have no surprises, and a valve that has a very short frame that can really allow me to work in the aorta for whatever reason. I want to work on the coronary arteries. I want to do another TAVR inside of it. I don't want to have hindrance with any kind of tissue on the aortic valve. And I want to have leaflets that hopefully have very good hemodynamics, so they're moving very well, they're not degenerating easily, and hopefully they're not too supraannular, meaning that they get away still from the anatomy of the aortic root itself. Because having supraannular leaflets, if we're treating very young patients, then can be sometimes a little bit of an issue in certain anatomies.
Excellent. Yes, I fully agree with you. And also, let's say we want to do another, we know that other than valves, also many other devices are being produced, especially in people with very small anatomies, in which we don't have so much space. We have been using basilica, which is this technique to cut the leaflet and have more space when we are to prevent any coronary obstruction when we are doing a valve in valve. Now we have also other devices. We have also other techniques on how to implant valves to kind of like push the valve towards one side and preventing the leaflet from obstructing the left main. Do you think this will be important and there will be more devices or technologies coming to minimize such risk in these patients? Because clearly we cannot remove the valve as a surgeon can do.
Yes, no. So the ideal scenario, I think, would be to be agnostic to the native valve, just like surgeons are. And what I think are the only two ways, it's either instead of making the leaflets come up whenever you implant a valve, you push them down and you avert them. And, but then there is the risk of these leaflets impinging on the mitral valve. And then there is the risk of these leaflets that are calcified, that you're not actually averting them, you're actually cutting them and having pieces fall over. So in my head, that's either averting them or either having a way to remove them, just like you said. Surgeons remove them. I'm aware of technologies that have been working on removal of leaflets. And after removal of leaflets, they go ahead and place a temporary valve in the aortic valve that can give you time to actually get a TAVR and then do a TAVR through the valve where there's no leaflets anymore. So definitely there's a lot of work still that needs to be done, but eventually I think the possibility of having a device that's agnostic to the native aorta is extremely important.
Excellent. Manaf, Matteo, do you have any questions for Pierre?
Thank you, Pierre. That was a wonderful talk, really a thorough review. And you covered a very broad range on a broad subject very well and very succinctly. So thank you for that. One thing that we often hear from our surgical colleagues is that as we implant these patients younger and younger, if they ever require explant, these procedures, we're not taking into consideration how difficult and how high the mortality is for these valve explants are. So just wondering, in your experience, in your reading, do you think that there's any role for new devices to make themselves in some way easier to explant in case of the need for that in the future? Should surgeons just be getting better at these surgical procedures in the future? Or should we just be focusing on making the TAVR valves so good that they don't ever need to be explanted?
Yeah, thank you, Manaf. Yes, this is, I think your last point is the ideal one. So make them good enough that we really don't need to expand anymore. But I think we still need a little bit of work to do that. So in terms of explant, so we've talked a little bit to surgeons, and I think, I don't think there's data out there comparing self-expanding tall frame valves and short frame balloon expandable valves. But I can expect that having a self-expanding valve with a tall frame that's like 50 millimeters tall and, it gets encased into the aorta with time and you remove it after 10 years, then maybe that might be more difficult than, a short frame valve that's only there at the annulus and you just, kind of crimp it, remove the native and shit. So in general, I think it might be something that's has an interaction with the type of valve that's implanted. I think right now, we're still at the beginning of TAVR failures, so surgeons are not exposed as much as they will be in 5 to 10 years. So obviously, the more the surgeons are exposed, I agree that they're going to be getting more hands-on and more expertise in this kind of procedures. But I think it's a very contemporary issue. And it gets down also to, those young patients that are like 60 years old, and you know that eventually they're going to have a sternotomy. But the question is, do you want to have it at 60 or you want to have it 10 years from now when your TAVR valve fails, if you do actually end up doing a TAVR at 60? So we don't have data right now, but if it were to be a TAVR at 60, then, there will be a lot of explants at 70. And if that's a higher risk procedure than standard TAVR, then that changes things.
Excellent. You also touched briefly about the pacemaker after TAVR. You showed how increasing pacing rates and also the more pacemaker, the worse the outcomes. We saw in one study, especially in people with reduced ejection fraction, in a study of self-expanding valves. And we also know that not all of these pacemakers are really needed. When we see the amount of pacing at 1 month and 1 year, on average, we can say half of them are still needed. So how do you see in the future how this can be changed and have like a sort of short pacing for the first 1-3 months? Is this a possibility, or maybe other options to prevent these patients to have a permanent pacemaker?
Yeah, no, that's another great point, and it's bifaceted. So on one side, sometimes we do implant pacemakers that we don't need, meaning that in the end that we see that the pacing and ventricular pacing is 0%. So in that regard, I think, and I think I've spoken with someone about, I remember this technology that was a TAVR valve that had some kind of intrinsic pacing technology that would work for a certain amount of time that would allow you to have some pacing if were needed. Of course, would be, I expect and imagine, just ventricular pacing. But it could be something that, in patients that you are very, very low risk, but still you're not feeling comfortable leaving them without, then that might be something that could be interesting. On the other hand, yes, we also need to think that oftentimes we implant patients with TAVR that have a pacemaker, and we pay a little attention on how much they're paced before TAVR. And then the concept is still the same. If they're paced 2% before TAVR and then you do a TAVR and you implant the valve very low, it's a self-expanding valve, you end up increasing the ventricular pacing from 2% to 50%. That's still an issue as well. So I think we need to look both ways.
Perfect. We have a very, very interesting question from Taylor Emilia, our interventional fellow. He's asking if you can comment on any difficulties experienced in enrollment of patients for these new investigational devices, especially considering that the ones we have on the market are quite safe and effective.
Yes, no, absolutely. That's a great question, meaning that TAVR itself has become a very, very much lower procedure than before. Patients are younger, and sometimes you have a discussion that, you have the possibility of enrolling him or her into a clinical study of a valve that's possibly going to be better. And that's a kind of a discussion that we always have when we deal with a research patient, meaning that I think as long as you explain very well the potential benefits patients understand, and also the potential risk of having to have a procedure with a valve that's not commercially available. And if it's not commercially available, there's definitely some reasons, because it's still kind of early in the process, and you can have always surprises. As long as you have an open discussion, I think you're good. And of course, always you're going to find patients that are very reluctant, and they're like, I just want to go with the commercial. Other patients are a little bit more eager to get informed about new technologies and get a little bit of taste of that. I don't know, what's your experience with that, Andrea?
Yes, I agree with you. I think also what we have to remind everyone here is that we have many devices, especially in Monti. We have the opportunity, thanks to Dr. Latif, to have all of them. And there's no valve that is better than all the others. So we always have to tailor our procedure and our planning on the specific patient. So as Pierre said earlier, maybe on a patient with a large BMI, we want to prevent any patient prosthesis mismatch. So we want to implant, maybe we are going to prefer a self-expanding valve, or there are many other conditions that will move us towards like one valve or the other. So let's say we want to enroll in a study with the newer generation device. We saw all the balloon expandable valves, Sapien, just to name the last ones, like Sapien 3, Sapien 3 Ultra, Sapien 3 Ultra Resilia, and now there was the X4, which the enrollment is complete in any case. But so we offer the patients, like, do you want the latest generation device, which is not commercially available yet, or do you want the one that you are using in everyday clinical practice? And many patients, when they see the updates and the change, they prefer to go for the newest one. Or let's say there is a new technology that for patients who are rejected by surgery and they have aortic regurgitation. We have been implanting off-label TAVR valves in these patients, but if we can offer them a dedicated device, which is designed for these people, it's safer and it's also more effective. So that's an important point that we have to discuss with our patients. And in this scenario, I think it's easier. It's not as difficult because it's not a one-to-one comparison like commercial versus investigational. We also have to tailor like our decision based on every patient. And I think that's how we move forward with research. We are not, in any case, we will never be offering patients any device that we don't think is going to benefit them. I think we have no other questions. So maybe we can conclude here. Pierre, thank you so much for giving us this brilliant talk. It was very, very interesting. Maybe we will repeat this next year and you will show us what's going to be in the future, a new update in 2026.